Well, good afternoon, and this is Chapter 12, the beginning portion of the 11th edition of the textbook of radiographic positioning and related anatomy. This chapter is actually going to be broken up into several lectures because it is so long. So the first portion of this is actually going to skip over pages 458, 459, 460, and 461. Those 4 pages reference the gallbladder and biliary system, and that will be a separate lecture to come later this week. So we're actually going to begin with figure 12.11 on page 462 in your book. And this is actually a picture of the entire alimentary canal, which extends from the mouth to the anus. Now, if you notice in this, which is, it's super frustrating, I feel like at times, but do you see here where it says chapter 14 and chapter 15 in this picture? But if you look in the book, it says chapter 12 and chapter 13. So that is correct. This portion would actually be chapter 12 in this part, and this is actually chapter 13, is just the large intestine that we look at. So I'll go ahead and erase all that, but I just wanted you to know that on this PowerPoint it is incorrect, but in the book it is correct. This would actually be chapter 12 and this is chapter 13, but sometimes when they change the slides for the new edition, they don't always pay attention to detail, so that is the only part that's wrong. But when they look at the alimentary canal, notice it starts at the mouth, and then as it travels into the mouth, we go into the pharynx, and the pharynx actually has 3 parts. It has the nasopharynx, the oropharynx, and the laryngopharynx. Then we go into the esophagus, which is this portion right here that carries food from the mouth all the way down into the stomach. So number 4 here is the stomach, and there are different areas, different anatomy to the stomach. This is just a general reference. And then from the stomach, we go into the first portion of the small intestine, which is the duodenum. And then we go into the jejunum, and then through and end up in the terminal portion of the small intestine, which is the ileum, spelled I-L-E-U-M. And then from the small intestine, we go through the ileocecal valve into the large intestine, and all of the large intestine is actually chapter 13. The accessory organs to digestion are your salivary glands, which are in the mouth, and those actually start to break down food once the food enters the mouth. And then you've got the pancreas, which secretes enzymes to break down the food. The liver produces bile, which also breaks down or emulsifies the fats in our diet. And then if you don't use the bile that's stored, if you don't use the bile that's produced, it ends up being stored in the gallbladder. So these 4 are accessory organs to the digestive system. The function of the digestive tract is basically to intake food and digest it. And then there's absorption of minerals and vitamins. And then finally, we eliminate the waste product that is left over. Some common radiographic procedures of the alimentary canal in this particular chapter are the esophagogram, or they call it a barium swallow. That would be one exam. And then secondly, an upper GI series. This image here is actually of an esophagram. The accessory organs in the mouth, like we said, we start with the salivary glands. And the salivary glands, there are 3 pairs, so we have 6 total. You have the parotid, which are the largest and sit on either side of your cheek. Sometimes when you eat something really sour, that's what they kind of cringe, and it just makes your whole mouth kind of pucker. Those are your parotid glands. And then we have submandibular glands that sit underneath the mandible. And then you have sublingual glands as well that sit underneath the tongue. And the purpose of the salivary glands is that during mastication, which is chewing, they secrete saliva into the oral cavity, and then they end up starting to break down. They start to break down your food. It dissolves the food and starts the digestion process. And saliva also carries what they call amylase, which breaks down the starches. So mainly it's water. There's a few little salts in there, and then the amylase, which breaks down the starches. And then once we swallow, which is termed deglutition, then then the rest of the digestive tract kind of comes into play and takes over. So 3 pairs of salivary glands, so 6 total. Mastication is chewing, deglutition is swallowing, and peristalsis is the alternating waves of contraction and dilatation that actually move food through the digestive tract. We will end up talking about the fact that when we swallow, fluids do tend to go down quicker. Solids do take a little bit longer. Don't mind Zero, he's just whining because his dad's home, so he's crying at the back door. Like we said, 3 parts to the pharynx. We have the nasopharynx, the oropharynx, and the laryngopharynx. And this is looking at the body from a sagittal section, so from side to side, from left to right or right to left. And then this coronal section would be looking at, looking like from the top of the patient down, like if you were to start slicing from the head and work towards the feet. And that correlates to figure 12.15 on page 463. You've got the tongue, which aids in swallowing. You've got the epiglottis, which kind of folds back over so that basically when that folds, it's so that food does not go down the trachea. And then you've got your larynx in here as well. So this correlates to figure 12.14 on page 463. All right. So these parts of the patient and the pharynx are important. You've also got the nasal cavity, the soft palate, epiglottis, like we said, that closes off so that food does not go into the trachea. Otherwise, the patient would aspirate. We want that to end up going down the esophagus and then through the alimentary canal. The esophagus is the next portion, and this correlates to figure 12.17. The esophagus is about 10 inches long. There are some indentations in the esophagus that we'll look at in just a minute, where it travels down. You can see that it actually goes, you've got the pharynx here, and then when the esophagus comes down, it goes near the aorta. You can see that it comes through the diaphragm behind the heart. So all of these organs end up pushing against the esophagus, which causes 2 indentations. You've got one indentation from the aortic arch, and then you also have the left primary bronchus, which makes an indentation. And this would be looking at the patient from the front. So you've got the heart, thoracic spine back here. You can see the trachea and the carina, where it bifurcates into right and left mainstem bronchus, and you can see the indentations in the esophagus from the front, and then you can also see these indentations from the side right here. Okay, so the esophagus again is about 10 inches long, and that is where we want food to travel down. We don't want it to go down the trachea, because then it would end up in the right or left mainstem bronchus, and the patient would aspirate. Some of the openings in the diaphragm, these diaphragmatic openings, you have 3. You have one for the inferior vena cava, another where the esophagus comes through, and then the third would be the aorta. So in this particular picture, it would be as if you were down by the patient's feet looking up this umbrella-shaped muscle is the diaphragm, so you're looking at it from underneath. And then from the side, you can see these same three things. You've got inferior vena cava passing through, the esophagus passing through, and the aorta passes through the diaphragm. Those pictures are on page 465, figure 12.19. This is a position of an esophagram showing you the entire esophagus full of barium passing into the stomach. And this same thing, different patient, showing you the mid and upper esophagus. Okay, let me back up for just 1 second as far as speaking. So on page 465, we talked about this just a minute ago, about swallowing. And with that diaphragmatic openings, recognize that when they tell you that, the reason they tell you that is because the diaphragm is what we tell the patient to either take in a breath and hold it, or blow their breath out and hold it out. So the junction of the stomach and your esophagus is normally attached to the diaphragm. So the stomach tends to follow the respiratory movements of the diaphragm. That's why breathing instructions are so important to the patient, whether you're having them breathe in and hold their breath, or blow their breath out, which is what we typically do with anything in the abdomen. Having them blow that breath out and then stop breathing is important because the stomach and the esophagus tend to follow the motions of the diaphragm. So very important to make note of that. As far as swallowing, recognize that swallowing fluids tend to pass through by gravity alone. Okay, gravity helps take fluid down from the mouth to the stomach. Gravity tends to have that happen in about 1 second, whereas solids pass with not only gravity but also peristalsis. And when that happens, it takes roughly 4 to 8 seconds for solids to pass. So fluids pass fairly quickly by gravity in about 1 second. Solids 4 to 8 seconds, and they not only gravity but also peristalsis is what helps move that food through the alimentary canal into the digestive system. We are skipping some pages that reference the stomach because upper GI will actually be a separate lecture as well. So when we're skipping pages like that, don't panic. I recognize they're there. We're just moving through that section for a little bit to go into fluoroscopy. So a similar picture to this is actually on page 472. And when we talk about fluoroscopy, we've mentioned before that fluoroscopy is actually radiography in motion. It's dynamic imaging, meaning that we have the ability to look at anatomy and record it in motion. That helps us to evaluate the function and the form of the anatomy that we're looking at, because you're looking at it live in motion, versus when we take our overhead images, those tend to be still pictures that capture one moment in time, whereas this could be recorded, and then the radiologist could play that back to actually look at and evaluate what is going on with that patient. The barium sulfate that we use, recognize that barium contrast media begins on page 473. On the contrast media, typically barium sulfate is considered a positive contrast media. We can also describe it as being radiopaque, meaning that X-rays do not pass through quickly. I'm sorry, not quickly. X-rays don't pass through easily. So the fact that it's radiopaque tends to, on our still images, things that are radiopaque appear white. Things that are radiolucent typically appear black. But positive things on our overhead images or our still images appear white, because those X-rays are considered negatives. Barium is a very chalky substance. It doesn't really have a bad taste. It kind of almost has no taste. Usually they will add some kind of flavoring to it to make it more palatable to your patient. Barium does tend to absorb more X-ray photons than to allow Compton scatter. It's not that you couldn't pass through the barium, but because it has a high atomic number of 56, it does take a lot more energy to pass through. And the chemical symbol of barium sulfate is this BaSO4. Okay? And there are pictures of some of the different contrast media on page 473. They show you some of the different brands of barium sulfate along with the gas-producing granules and tablets. This cup of barium can be thin or thick. They reference that barium is actually considered a colloidal suspension. Okay, the fact that it's a colloidal suspension is important because when we ask what is barium considered, it is considered a colloidal suspension, meaning it's never going to mix completely with water. Barium is never going to mix with water. It's always going to separate, which that is what they're showing you in this picture here, which is figure 12.47 on 473. So this brand B has the least amount of separation. I'm assuming they all sat for the same time frame, but this one has the most separation. So eventually what will happen, kind of like with oil and vinegar, you can shake them up and they'll stay together, but eventually they will layer out and the oil will settle and the vinegar would rise. So with barium, the same thing happens. You end up with a separation, which is not good if you're trying to do imaging, but this brand tends to show that it stays together longer. But barium is a colloidal suspension, so it will never dissolve in water. The rate of separation definitely varies by brand. And this is extremely important. Okay? These contraindications are extremely important and they will not change no matter what. When we're talking about contraindications to barium, it doesn't matter what exam you're necessarily talking about, but if the patient has any of these conditions, then you would not use barium. Okay, so there's three. The contraindications or the reasons to not use it would be a possible obstruction, a possible perforation, or if they are having or had surgery within the last 48 hours. All right, so any of those reasons, there's possibly an obstruction, there's possibly a perforation in their stomach or in their intestine or in their esophagus, or they had surgery within the last 48 hours, or they're having surgery within the next 48 hours. If any of those conditions exist, then they would give the patient not barium for contrast media, but they would give them what is called a water-soluble iodinated contrast media. We talked about this in patient care because we said that if any of these conditions existed and you did give the patient barium, the potential would be that they could get acute barium peritonitis, where the barium leaks into the peritoneal cavity and there's no way to get that out. The patient could become septic and die. Not a good day. But when they give them the water-soluble iodinated contrast, the body tends to absorb the iodine a little bit. It's a little more used to that, so the body tends to absorb the iodine, and it's not nearly as harmful as the barium could be. But this is not a call we make. This is the radiologist that makes that decision whether or not the patient gets the barium or the water-soluble iodinated. The reason it's brought up, though, is it is our job to interview the patient through our history taking and make sure that they have whatever the reasoning is. Is the doctor thinking possible obstruction? Are they thinking a possible perforation? Or are they having or had surgery within 48 hours? Some of the barium that they show you, now these pictures don't correlate to the ones that are on page 473, but they do tell you that most barium sulfate is prepackaged, okay? Meaning you add water to the cups by mix, and then you mix the barium together. So some of them do come in a liquid form, which means that it's already mixed together. Some of them come in powder form, and then you add water according to the radiologist's preference of whether they want thin or thick barium. Okay, so this does reference really thick barium. We'll talk about that in a minute. But typically thin barium has a pink label, and the ratio of the barium thickness would be 1 part barium to 1 part water. So relatively thin, not as thin as water, but maybe like milk, like 2% milk, I would say. That's probably about the thickness of thin barium. So that's pre-mixed. If it's thick barium, this is not a picture of thick barium. The difference would be, compared to thin, thick barium has a ratio of 3 to 4 parts barium to 1 part water. Okay, this particular thing right here, this is considered a barium paste. If you look on 473 in figure 12.49, there is a tube of Veribar pudding, and notice it says barium sulfate oral paste. So this is what it would look like. It almost looks like marshmallow cream. That's about the consistency of it, is like marshmallow cream. And they use this during esophagograms. They can really use it in anything they want, but it's a lot of times used in esophagograms or in what we call video swallows. All right, so to stay on that for a second, they don't really talk about it in this chapter, but just to give you an idea, there are exams that we do that are called video swallows. And what that is, typically that is an exam that is done on a patient who has, it's not the only reason, but a lot of times the patient has had a stroke. And what they're trying to figure out is what the patient can and cannot tolerate as far as when they eat, what causes them to start to choke or not be able to continue like eating. Usually it's a stroke patient, and it's performed by a speech therapist, and then we are also in the room. Typically us, a speech therapist, and the patient are the only ones in the room. And what they do is there's no images done, but they record the entire procedure, and they give the patient different consistencies of barium. So on 12.49 in the 11th edition, page 473, you can see they've got all the way to the right, there's a green bottle of thin liquid. There is Veribar nectar with the pink label. Then they've got the pudding on there that's a thick paste. And then the one all the way to the left says Veribar honey. So those, think about it, those consistencies. So the thin would be like 2% milk. The nectar might be a little bit like, almost like orange juice with pulp. The pudding is exactly what you would think, kind of like this marshmallow cream paste. And then the Veribar honey would have that consistency of honey where it's kind of a little bit thicker, a little bit gooier. And the speech therapist would give these to the patient one by one. They would label on there the different consistency that they're giving them, and the entire exam is videoed, and the imaging is videoed, and we are simply there to set up the tray for the speech therapist. We might hand the different consistencies, to the patient, and then the entire exam is recorded, and the speech therapist goes back and views it and actually watches all the motion that goes on when the patient swallows, and whatever causes them distress or to start to cough or choke or sputter. What they do is they come up with different exercises to strengthen those muscles so that ideally their swallowing capability improves. Oftentimes this exam, after they've gone through physical therapy and had those exercises, they're doing those exercises, they could very well come back in for a follow-up exam to see if they've improved with the consistencies in what they ingest and how they do that. Okay, so what's the takeaway? Thin barium tends to have a pink label. It's very thin, a 1-to-1 ratio. Thick barium, typically the bottle has a green or a blue label. Green is more common, blue is the older color, but that is 3 to 4 parts barium, 1 part water. If the label on there is black, then it means that you mix it to the consistency that the radiologist asks for. So it would be powder, and if he says, I want thin but not all the way thin, but not quite thick, then maybe you're 2 parts barium, 1 part water, and then you would mix that up, because it is a colloidal suspension, which means you have to continually shake that before the exam starts so that it doesn't layer out. Now, those contraindications we talked about. If the patient has contraindications, then they would not be given the barium, but they would be given water-soluble iodinated contrast media. Okay, and that is on page 474, figure 12.5. They show you a smaller bottle of gastrographin. This is actually called GastroView. Both of these, gastrographin and GastroView, are the water-soluble iodinated contrast that can be given to a patient that has a possible perforation, a possible obstruction, and or has or had surgery within 48 hours. This is atomic number 53. The problem with this is, though, that if a patient has an iodine allergy, they're not able to eat shellfish, then they could not have this particular contrast media. All right, so contraindication is hypersensitivity to iodine. So, for example, I am deathly allergic to iodine. I go into anaphylactic shock. My throat would close. I could not breathe. Death would be imminent. So I could not have this. I could not ingest that. So if I had one of those contraindications and I could not have the barium, I also could not have this. So they would likely have to do the exam a different way to figure out how to get my imaging done. All right, so this is the water-soluble iodinated contrast, atomic number 53. It is also a positive contrast media. It is radiopaque, and it would cause absorption versus scatter. It would be more likely that you would have absorption. That's why it shows up bright on our X-ray images. But if the patient has an iodine allergy, then they could not have this, meaning you would have to let the radiologist know that, and they would have to figure out how they would do the exam, because it would need to be done a little bit differently. All right, this part here, it is something to do with upper GI. I just kind of wanted you to recognize that they can order single or double contrast studies. Okay, so this is talking about an upper GI. So if it is whatever it is, if it's a single contrast study, then what that means is that the patient is given one positive contrast media. Okay? If they order a single contrast study, the patient is given one positive contrast media. So they are either given barium or the water-soluble iodinated contrast. If they order a double contrast study of whatever, you can have a double contrast upper GI, a double contrast BE, single contrast upper GI, a single contrast BE. Anytime it's single, it means one contrast. Double implies two. So when there's two contrast medias, what happens is you have one positive contrast media, which typically is either the barium or the water-soluble iodinated contrast, and then a negative contrast media, which is typically either room air or carbon dioxide gas. They're crystals. If you look on page 473 at the very top in 12.46, you can see the in front of the cup it says easy gas 2. Sometimes I refer to those as fizzy crystals because it's kind of like Alka-Seltzer or Pop Rocks, and we can let the patient put those in that little medicine cup. The radiologist would hand them to the patient and tell them to throw them to the back of their mouth and then swallow some barium, and then those crystals start to break down almost like a pop rock, and it causes air in the esophagus and in the stomach so that it acts like a double contrast study. So with a double contrast study, you have one positive contrast media and one negative contrast media. With the digital fluoroscopy, this is on page 475. Typically, digital fluoroscopy is computer-based. We have no cassettes that are required anymore. You can do multiple frames in one session, and you can post-manipulate the image. Post-processing, you are able to manipulate that image. So they show you in 12.54, they show you this would be an RF room because you have a radiographic tube like you've been using throughout the week. And then there's also a fluoroscopic tube, which is under the table. So this would be in a general RF room. You would have two tubes, two ways to be able to image the patient. This would provide still or static imaging. This would provide dynamic imaging or imaging in motion. And then when you do the fluoro, the radiologist and yourself and potentially the patient is viewing what's going on the monitor. Okay, so with digital fluoroscopy, basically there are flat panel detectors in a computer to manipulate the image and to store that. This is figure 12.53, the C-arm digital fluoroscopy system, and notice this orientation is typically how you would find the C-arm, with the image intensifier at the top and the X-ray tube at the bottom. Okay, and then this is the table for the patient to lie on. So this is a C-arm. You can tell by the shape of it, it does look like a C. All right. These aren't just hard copy digital images. The point I wanted to make with this is, remember on X-rays that barium positive contrast media appears white and negative contrast media would appear black because X-rays are negatives. The images are negatives. But in fluoro, the image is a positive, which means everywhere there is radiopaque material, it's the opposite. So instead of all of this appearing bright and white, it appears dark. And everywhere Like look at the bone in comparison to the barium. All of this would represent air, which normally that would be black, and it's not, because fluoroscopy is actually a positive. So everything white would become black, and everything black would become white. Why? Because fluoro is an opposite of your still image. So that was the point trying to be made with these particular images. They are on page 476, figure 12.55. So everything is opposite when you're looking at fluoro. Some of our worker protection that is required when we're doing fluoro, some of the things we have. This is showing you your fluoroscopy exposure pattern. And the takeaway from this is that near the patient's head and the patient's feet is not an ideal place to stand. Okay? Will we have to stand there occasionally? Yes. But you don't want to hang out at the head or the foot of the table. All right? This alien looking thing is supposed to represent the radiologist. They have lead gloves on their hands. They may or may not do that. These right here, these black things right here, are the leaded drapes that hang down from the fluoro tower. This is supposed to represent they are wearing an apron. And there is also what's called a Bucky slot shield that we'll look at in a minute. But notice, as far as radiation, if this orange represents radiation, where they're standing, there's not a lot of radiation, not to mention that they are protected by their lead apparel. Right? So I'm not saying, no, we won't stand here. I'm saying you don't want to stay there. If you have to step up to help the patient do something, then step back. I always tell you the safest place to stand is behind the radiologist. This is actually in your book. It is figure 12.59. This is what's called a Bucky slot shield. All right, and you can see that this is the Bucky. So when you do fluoroscopy, you move the Bucky all the way down to the foot of the table, and that will bring out this leaded Bucky slot shield that closes the gap between the tabletop and the bottom of the table. That is about probably a 3 to 4 inch gap. And if you're standing by the table, the problem is that that is usually near the gonads. So we want lead in there to potentially block any radiation from coming out of there and striking the gonads. But if you're wearing your lead apparel, as you should, then even if radiation were to get through there, it would likely be absorbed in your lead apron. Okay? Those lead aprons, just to make a point with this, your lead aprons have to have a 0.5 millimeter lead equivalency, and that is because when we operate above 70 kVp, that is what is required for the lead aprons. You can see in figure 12.4, I'm sorry, table 12.4, the protection summary chart. There are lead tower drapes on the fluoro tower that help protect us. We wear protective lead aprons of 0.5 millimeters lead equivalency, and that is because we operate above 70 kVp. The lead gloves should be 0.25 millimeters of lead equivalency. The Bucky slot shield is 0.25 millimeters of lead equivalency. If we have protective eyewear, that should be 0.35 millimeters of lead equivalency. And our thyroid shields, those should be 0.5 millimeters of lead equivalency. Okay, so we have all kinds of protective apparel available to us. You definitely want to make sure that you're utilizing that, along with the fact that you should be wearing your OSL or your radiation dosimetry badge on the outside of your lead apron up near your collar. Like ideally this technologist should have this lead, should have their dosimeter clipped onto this lead on the outside of the lead apron up near their thyroid. They could put it here, they could put it on the burgundy apron here, but it's worn on the outside of the apron up near your thyroid. Don't forget, we also have our cardinal rules of radiation protection, which are time, distance, and shielding. Okay, so time, reducing the amount of time that the fluoroscopy tube is energized would be important. You want to make sure that if they're utilizing time, sometimes they'll make it, like a pulsed image, so that it's not always on. It just kind of pulses on, off, on, off, on, off. Shielding, not in the way we normally think of patient shielding, but you want to follow all shielding precautions by wearing your lead apron, making sure that the lead drape shield is on the fluoro tower. The Bucky slot shield is enacted by moving the Bucky all the way to the foot of the table, and wearing your lead gloves if they're needed or if the radiologist needs them. And then the most effective way, the third cardinal rule of radiation protection, distance is the best thing that you can do. It's governed by the inverse square law that says when you the intensity of radiation is inversely proportional to a square of the distance from the source. Meaning, if you are able to double your distance from the source of radiation, if you can double how far away you're standing, you will reduce your radiation intensity to 1/4 of the value that it was. And that is pretty significant. So standing behind the radiologist or just taking one giant step backwards is extremely helpful to lower your radiation dose. All right, we are going to move into an esophagogram. Okay, so an esophagogram is one of two procedures in this chapter. This actually comes from page 478, and these are some reasons why a patient might have an esophagogram ordered. There could be some anomalies, anatomic anomalies the patient has. They could exhibit esophageal reflux. They could have esophageal varices. They might have a foreign body obstruction, an impaired swallowing mechanism. They could have esophageal cancer. There's all kinds of clinical indications: achalasia, Barrett's esophagus, dysphagia, GERD. Maybe they have gastroesophageal reflux disease. These all come from 478 and 479. Maybe they have Zinker's diverticulum. So these are some of your pathologies that you would have listed, and those are found on page 478, 479, and 480. Foreign body in the esophagus. If that were the case, a lot of times what they can do to identify that is that we can actually give the patient the barium. Sometimes what they'll do is they will actually give the barium to the patient in the form of, they'll take a cotton ball and they'll soak the cotton ball in barium and then have the patient swallow that so that they can visualize where that foreign body is. I've also seen where they could take mini marshmallows and they can soak those in barium and then have the patient swallow a mini marshmallow, and that would kind of outline where in the esophagus that foreign body could be. So fishbone is one that I have listed here. I've seen a patient accidentally inhale a sewing needle while she was holding the needle in her mouth, getting the thread ready. Fish bones, chicken bones, coins. I've seen little kids swallow coins before. Just anything anything that is radiopaque, that does have the potential for it showing up on our x-ray imaging. So they could soak a cotton ball in barium, or like I said, they could use mini marshmallows and soak those in barium. This is another, the pathologies. I think the slide got out of order, so I apologize for that. All right, some of our responsibilities as the technologist getting the fluoro room ready. Our job is basically to prepare the fluoroscopy room. This starts on page 481. They tell you that, you know, we have to prep the room along with the patient, but we have to get everything ready. We prepare the contrast media, we obtain the patient's clinical history, and we explain the procedure to the patient. We also should introduce the patient to the radiologist when they come into the room. Sometimes the radiologist will introduce themselves, which is fine. And notice in the book that they don't always say the radiologist. Sometimes they'll call them the fluoroscopist. The reason for that is because whoever's performing the fluoroscopy, that's who they're referencing. So it might very well be a radiologist, but it also could be a radiologist assistant. So they just use the term fluoroscopist, meaning whoever is doing the fluoro, but the fluoro cannot be done by a technologist. That is outside our scope of practice, but it is within the scope of practice for a radiologist assistant and or a radiologist. The patient does start in an erect LPO position on the end of the table. So these pictures, these two pictures are similar to figure 12.66 and 12.67, but they're not exactly the same. Different models, different people in the picture, but this table, you can see behind her that the table is upright, and there actually is what's called a footboard attached to the table. So the table does start upright, and so does the patient, and they would stand with their back against that board in an LPO position. They do reference in figure 12.68, which this is similar, different model again. These are the lead drapes that they were talking about that are 0.25 millimeters lead equivalency. This right here is the Bucky slot shield. The patient has the fluoro tower over the top of them. That can come down closer to the patient. Once the radiologist starts, they can lower that so that it's closer to the patient. And they reference that in an RAO, a lot of times the patients end in this position before the radiologist or the fluoroscopist hands the patient over to us to get our overhead images. On page 482, they do give you a couple different things that can be done during the exam to demonstrate esophageal reflex. If you look on the breathing exercises, okay, they reference the Valsalva maneuver. And the Valsalva maneuver is done when you ask the patient to take in a deep breath, and then while they're holding their breath, the radiologist typically asks the patient to bear down as if they were having a bowel movement. So they take in a breath and then they bear down like they're having a bowel movement. And what that does is it forces air against the glottis. And a lot of times if that's the case, then you can actually see the barium come back up out of the stomach into the esophagus, and it starts to reflux. So that is one way, by them performing the Valsalva maneuver. Another thing they can do is what's called the toe touch maneuver, and that is figure 12.71 on 482. You can see the patient is kind of bent in half, reaching for her toes under fluoro. That will actually demonstrate a hiatal hernia. Okay, so Valsalva will demonstrate reflux, the toe touch will demonstrate a hiatal hernia. That's the instructions for a Valsalva. That is not something we typically tell the patient. The fluoroscopist would tell the patient to take in a breath and bear down like they're having a bowel movement. There is a picture of the compression paddle in figure 12.7 on 482. This is what the compression paddle looks like. This bulb syringe will blow up this rubber area in the center of this, and they use this almost like an extension of their hand. So the radiologist or fluoroscopist would hold on to this, inflate it as much as they wanted, and then they can use that paddle to kind of push and move the barium around to look at different things in the patient's stomach or intestines as they need to. But this is used instead of them placing their hand in the path of the primary beam. Actually, during fluoro, it wouldn't be the primary beam, it would actually be the remnant beam. But they use this paddle as an arm extension. There's a picture of the toe touch. This is actually a picture of the footboard that gets attached to the table. You can see this gap. So the bucky is not pulled down like it should. And this is the gap that we're talking about, that bucky slot shield covers. Because that's a pretty significant gap. And figure the tube is down here and radiation is coming up this way, which means that a lot of radiation has the potential to leak out here. So that's the need for that bucky slot shield. The footboard is attached to the table, and typically we step on that to make sure that it's not going to go anywhere, make sure the patient's not going to go anywhere when we put them on there. And then we have them stand up there. Initially, they're erect in an LPO position, but this toe touch maneuver demonstrates a hiatal hernia. Okay, now we have positioning for an esophagogram. And that starts on page 490. Okay, we'll talk about an esophagogram. The positioning starts on 490. The patient prep for an esophagram. Typically, the patient has no dietary restrictions prior to the study, unless they are going to have an upper GI to follow. So as far as where that comes from, that actually comes from page 481. And they tell you that because the esophagus is empty most of the time, patients need no prep for an esophagogram unless they're having an upper GI to follow. If they were having an upper GI, then they would need to be NPO, or nothing by mouth, for at least 8 hours prior to the exam. For an esophagram, they typically are removing all clothing and any metallic objects between their mouth and their waist. So it's typically everything all from the waist up, including top, bra, and any metal items, any piercings, any jewelry that could potentially get in the way. And then they would put a gown on open to the back. As always, when we're going to image, any kind of imaging or any radiation is used, you want to determine pregnancy before you actually change your patient and get them started. We will talk about a scout exam when we're in person. I'll mention what some facilities do for a scout image for this prior to the study, but not everywhere does it, so we'll talk about that in person. They do reference in here as well that some additional items that are useful to detect a foreign body are cotton balls soaked in barium. They use barium pills or capsules, and they can use the mini marshmallows. Okay, so that is where I got that information from to tell you as far as foreign bodies, that's what we can do for that. All right, the room prep, like we said, typically the table will start in an erect position with the footboard attached, and you want to test that footboard and make sure that the patient's not going to go anywhere when they stand on that. The bucky would need to be all the way down. You can see it's right here, but it's not all the way down because this Bucky slot shield is not fully extended, so it would need to be fully extended. You can see the monitor is here so that the fluoroscopist is able to look, and we would be able to look as well. Sometimes they'll point things out to the patient so that the patient can see, but our biggest job in fluoroscopy is helping the radiologist or the fluoroscopist and helping the patient. Usually once they get some images of the patient upright, we give them the barium in their left hand. So patient stands on the table in an erect LPO. The barium's given to them in their left hand so that it doesn't obscure anything when they drink. They would drink and the fluoroscopist would have them turn in different positions, and then they can take pictures with this fluoro tower. At some point during the exam, they'll lay the table down, have the patient roll around into some different images and take more pictures. And when they're done with all of their imaging, they would leave the room, and then we would come in and take over the rest of the exam, and we would typically do what are called our overhead images, or the images that are taken after fluoroscopy. Now, this is where it gets a little bit confusing, not like anything else in our field isn't confusing, but with the invention or addition of digital fluoroscopy, because the fluoroscopist has the capability to take the imaging during fluoro, sometimes, and I would say most often, they are not doing the overhead images after the exams. Okay, now that's not a horrible thing, especially for the patient. It's less dose. The problem comes that the registry says we need to perform a certain number of exams before we can sit for the registry. So because of that, it makes it a little difficult to get your fluoro comps when they don't do the overhead images. So these images will not be comped in the lab because most of the time for an esophagram, they do not do any overhead images. But the registry is still going to test you on these images for an esophagus. So we are going to talk about what would be normally done with this study. Okay, and this just isn't here. This is literally nationwide. They are tending to do away with overhead images after fluoro. In an esophagogram, there are typically 4 views that are done after the procedure. But I will tell you that only 2 of them are really diagnostic and provide information. That is your RAO and a lateral. Either lateral, right or left, it does not matter. Those 2 are the most diagnostic out of the 4. These other 2, the AP or the PA and the LAO, are the least diagnostic, meaning they provide little to no information. These 2 provide the most information. So if the radiologist is going to have you do any, they're going to have you do an RAO and a lateral view. The RAO is on page 490. You would be at a 40-inch SID, and you're going to be on a 14 by 17 portrait with collimation from side to side. The patient can be either prone, technically. They can either be on the table or they can be upright. I will tell you, if they're upright, then that position is a lot easier on the patient, but it would be more challenging for us to get the esophagus full of barium. So if the patient is standing up, It's a lot more difficult for us to get the images that we need, but it's easier on the patient. So I will be honest and tell you, I have never done an esophagram upright. I have always had the patient lying down like she is here in an RAO. So the patient lies on the table on their stomach, and then they would roll up into an RAO position, meaning their right anterior portion is closer to the IR, because this is an RAO position. They're in a 35 to 40 degree oblique. Their right arm is down behind them by their side, and the left arm is bent like this to actually hold the barium cup. This is the same image, different model in figure 12.82 on page 490. The model is just a different model. Okay, so 35 to 40 degree oblique. Those are the things that the registry likes to know. What's the degree of obliquity on an RAO for an esophagram? What's central ray on an RAO for an esophagram? Central ray is T5, T6, which is about 1 inch inferior to the sternal angle. This, in the book, they tell you central ray is to the level of T6, 2 to 3 inches inferior to jugular notch. Both of those are fine, except that if they're laying in an RAO, the chances of you feeling their sternal angle or their jugular notch is not going to happen. So T5, T6, if vertebral prominence is C7, T1, then that means you're about 5 to 6 inches below the vertebral prominence. In order to fill the esophagus with barium, the patient will have to drink and swallow quite rapidly. Usually what you would have to do is they would have a straw, and you would tell them, when I tell you I'm going to have you take in a mouthful, swallow, take another mouthful, swallow, take a third mouthful, and swallow, and then you're going to take the picture. So you would tell the patient, go ahead and take a drink, swallow, drink, swallow, drink, swallow. If you do that, then ideally you will fill the entire esophagus with barium. That's your goal, is to have the esophagus full of barium pretty much from the laryngopharynx all the way down into the esophagogastric junction. Okay, so you need to demonstrate the entire esophagus, and this image is one of the two that are most diagnostic because it places the esophagus midway between the spine and the heart. Okay, so this is actually one of the two most diagnostic images. The second most diagnostic is a lateral esophagram. That is on page 491. You're still at a 40-inch SID, still a 14 by 17 portrait. You're still going to be centered to T5, T6. And the patient is going to have to drink, swallow, drink, swallow, drink, swallow. I realize I did not give you technique on this. I would tell you that the technique is on the RAO would be 110 kVp at 2 mass. Okay, 110 kVp at 2 mass for a single contrast study. If you're doing a double contrast study or using the water-soluble contrast, you would be 90 at 2. So 110 kVp at 2 mass for a single contrast. For the double or water-soluble, you'd be 90 kVp at 2 mass. That's for the RAO. On the lateral, your technique would be 110 kVp at 4 mass for single, and you'd be 100 at 4 for double or water soluble. 110 kVp at 4 mass for single, 100 at 4 for double or water soluble. Now on this lateral, you're still, like I said, T5, T6. You're likely collimating from side to side on these to about 6 inches in width, because the esophagus is not that big. And when it's filled with barium, you're probably looking at it being about 1 inch in thickness. And if you do that correctly, you would end up with an image very similar in full, I'll show you that in a minute, of the esophagus full of barium. But before we get to that, look at the bottom of page 491, and they show you what's called an optional swimmer's lateral. Okay, so this swimmer's lateral is better to visualize the proximal esophagus. All right, so when the issue is with the upper esophagus, a lot of times this shoulder, when they're in a regular lateral, this shoulder would be right over the top of this one. But in this picture, you can see they're dropping she's in a right lateral. So she's dropping her left shoulder back. Her arm is back behind her, but her body is staying straight up and down. But when she does that, it allows better visualization of the upper esophagus, because you're actually pulling the shoulder and the humerus out of the way. Okay, so sometimes they'll ask you if the patient had an anomaly in the upper esophagus, what could you do in the lateral to better demonstrate that? Your answer would be you would do a swimmer's lateral. The reason they call that a swimmer's is because typically when you swim, you have one arm like going towards the water and then one arm coming back to go back in the water. So that's why it's kind of like represents a swimming position. If this is done correctly, like I said, you would fill the entire esophagus with barium so that it could be evaluated. And this is the only view that will show anterior posterior aspect. It's the only view that shows depth. Okay? The lateral is the only view that shows anterior posterior aspect or depth. So if you were trying to look for a foreign body, this is the only one that's going to tell you, where is it from front to back. All the rest of them are pretty much considered frontal views, and you're not going to be able to visualize that. The esophagus is midway between the spine and the heart. So you've got heart here, spine here, and then the esophagus is in the middle. Those two, the lateral and the RAO, are the two most diagnostic images. The AP or the PA is kind of useless. It's on page 492. Your technique would be the same as an RAO, 110 at 2 for single, 90 at 2 for double or water soluble. Your central ray is still T5, T6. They would drink, swallow, drink, swallow, drink, swallow, beep. The problem is for this that it places the esophagus right over the spine. So this is not a very good image to get much information out of this. It is the least diagnostic image because it's placed right over the spine. And the last of the 4 overheads for an esophagram, and it is also not very diagnostic, is your LAO, and that is on 493. It is also a 35 to 40 degree oblique. Your central ray is still T5, T6, still at 40 inches, collimated about 5 to 6 inches from side to side. 17 inches long because you're on a portrait IR. The patient's going to drink, swallow, drink, swallow, drink, swallow. But the reason it's the second least diagnostic image is because this ends up placing the entire esophagus between the spine and the hilar region. Okay, and it should be, the entire esophagus should be full of contrast media, but it is not a very diagnostic image. It is the second least diagnostic. So technically four images for an esophagogram: RAO, alateral, right or left, AP or PA, LAO. But out of those four, the first two are most diagnostic, an RAO and a lateral. The AP or PA and the LAO are the least diagnostic. Whew, I know that's a lot of information. That is one portion of chapter 12. Like I said, upper GI will be a separate lecture, along with gallbladder and biliary system. That will also be a separate lecture. So 3 lectures out of this one chapter, but all the information about the barium and the contrast and the positive and the negative is only found in this lecture. So make sure you take your notes, make sure you come to class with your questions, and I will see you all super soon. Have a great rest of your